question by Senator Daniel Manzo. That is question 033. That question has since been deferred pursuant to a request by the said senator who is not present. So that will not be responded to today. Senator Tabitha, you may proceed to ask your question.
Thank you, Mr. Speaker. Allow me, Mr. Speaker, before I ask my question, just quickly, through our standing orders, that is Standing Order 51C5, to read, and it states, a CS, Cabinet Secretary, shall provide a physical or electronic copy of a response to a question at least 24 hours before appearing before the Senate. I would like really to request that the CS office, CS Health, the CS having been a member of this, not really of this House, but of Parliament, knowing very well that at least we need maximum time to be able to look at the responses so that we can be able to engage from that. So it will be kind to note that your team does deliver the response on time because it has been received this morning. Thank you, Mr. Speaker. As I proceed, my first question was, what is the current annual budget?
Senator Tabitha.
Yes.
Are you saying that since the response has been received this morning, you're unable to interrogate that response effectively? Is that your position? Or despite it having been received this morning, you're still comfortable interrogating the response? If that is the case, then you may proceed to...
Thank you, Mr. Speaker. The response has been received this morning at exactly 9:30 as the chamber was starting. Luckily, I've been able to go through the responses, and I'm okay. We can be able to engage. My first question was, what is the current annual budget allocation for Linda Mama program and how these funds have been distributed across the 47 counties and public health facilities, including a breakdown of allocations for financial year 2024-2025 to date under SHA, or the Service Health Insurance Fund, that is Shif. Mr. Speaker, the second question, has the benefit package of Linda Mama changed the following its transition under Shif? And if so, what are the specific changes in coverage, benefit amounts for normal and cesarean deliveries, and eligibility criteria? Number 3, Mr. Speaker, what safeguards are in place to ensure that funds allocated to Linda Mama are used exclusively for maternal and child health services, and that indigent mothers, especially in rural and marginalized areas, receive full benefits without undue delay? And lastly, Mr. Speaker, what steps the ministry has taken to ensure access to Linda Mama services in under-resourced or understaffed health facilities, and how it is addressing barriers faced by mothers in remote and hard-to-reach areas under Shif structure? Mr. Speaker, I submit my questions.
Honorable CS, you may now proceed to respond.
Thank you, Mr. Speaker and honorable senators. Let me, Mr. Speaker, first apologize, and I think it's on my side that going forward I will comply with the standing orders and provide the answers, not even 24 hours, but 48 hours. These I even had to raise with my staff this morning, and it's an oversight. It will never happen again. Honorable Speaker, on the first question, on why, what is the current annual budget, question 1, which the senator has said, my answer is this. The Linda Mama program is not currently administered under the Social Health Authority infrastructure. While the program was instrumental in expanding access to free maternal care, it is important that it faced very critical challenges that necessitated a shift to a more comprehensive and sustainable model. And these were all anchored in the 4 laws that were passed by this House. These challenges, Mr. Speaker, included frequent financing constraints, budget cuts, delay reimbursements, significant access and equity gaps, especially for adolescent mothers without identification, and a benefit package that was not comprehensive because it was excluding critical maternal and newborn services like complications and the NICU care. And in response, Mr. Speaker and honorable senators, the Ministry of Health, through the Social Health Authority, has adopted a very comprehensive household coverage model to ensure all vulnerable families can access a broader range of essential health services. And that's why, as part of this strategic framework, the national government, through SHA and the Ministry of Health, is sponsoring 558,000 indigent households, which were identified through the State Department for Social Protection Enhanced Single Registry in order to access healthcare under SHA. And this is ongoing. Governors have come in, members of parliament, and many other philanthropists are coming in to support this program. Furthermore, recognizing teenage pregnancy as a very critical public health challenge in our country, the Social Health Authority has also introduced a very deliberate, targeted intervention for adolescent mothers and their newborns, leveraging digital health platforms and using our community health promoters. SHA now can facilitate real-time registration of these vulnerable groups, ensuring equitable access to subsidized care. And I'm happy to report that to date, 22,000, since SHA came into being, 22,000 teenage mothers across our country have accessed maternal services free of charge. The allocation of funds now operates on a fee-for-service model where funds follow the patient via claims, and this has replaced the previous fixed pre-allocation sort of budget. Question B was on the benefit package of Linda Mama. Honorable Speaker and members, the transition under Shif has significantly expanded the former Linda Mama benefit package from a very narrow maternal focus to a very comprehensive household coverage model, now known as Linda Jamii scheme. While delivery services remain very central, reimbursement has improved through a fee-for-service model, and which is aligned with the actual service cost, and this has given us and strengthened inclusivity for all vulnerable households across our country. And the table, Honorable Speaker, that I have provided shows the scope of coverage under Linda Mama and under the new Shif SHA program. I really don't want to go. It shows the reimbursement model, the eligibility, the scope of coverage, and if I pick on, for example, the scope of coverage, under the, before Linda Mama, this was limited to maternal health, ANC, formal, and C-section delivery at our primary network centers. But under Shif and SHA, comprehensive household coverage, which include outpatient, inpatient, emergency and surgical care, chronic disease management, maternal and newborn care, including all the complications, is now covered under the Linda Jamii. If you look at the reimbursement model, Honorable Speaker and members, Under the Linda Mama, there was a predetermined fixed rates paid by NHIF. There was, the fee for normal delivery was 2,500 for level 2 and 3, and 3,500 for private and faith-based level 2 and 3, and 5,000 for public facilities, and 6,000 for faith-based facilities and private level at level 5 and 6. C-section was Kenya shilling 17. But if you look at the fee-for-service model under Shif, the facilities reimbursement is based on the actual service rendered at the approved tariff rate and passed by the House. And then there's standardization of the reimbursement. Now, both faith-based, private, and public, women can have delivery, and SHA will reimburse 10,000. For cesarean section, 30,000 because of equity, whether they go to public hospitals, whether they go to private hospitals, whether they go to faith-based hospital. And then eligibility is different. Under the Linda Mama, eligibility was only targeting pregnant, but adolescents and undocumented mothers were often excluded. But now if you look at the Linda Jamii or the Shif, under this transition, indigent households are identified via a very proxy mean testing as per the law, as per Section 27 of the Social Health Insurance Act of 2023. So pregnant, adolescents, and newborns are all included through a very targeted intervention using a temporary ID, and the entire household is covered under the Shif Comprehensive. So where the teenage mother can either use her birth certificate, she can use her parent identification, and the system has created a special ID to identify those important section of our mothers who are the teenage mothers. Question 3 about the safeguards. Honorable Speaker and members, several safeguards have been initiated to ensure that the funds are allocated for maternal and child health services, and that vulnerable mothers receive full benefits without undue delays. And what have we done? We have done, number one, we have introduced legal and policy safeguards. The Social Health Insurance Act of 2023, which this House has passed, mandates proxy means testing to ensure that only eligible vulnerable groups are covered, and this is anchored in the use of the funds within Section 27. 2, and more important, digitization and transparency. Reimbursement are processed through digital platforms that validate service for payment. They minimize fraudulent claims. Real-time registration is done through digital health platforms. Our community health promoters help us to instantly enroll to ensure timely access, especially in the most remote part of our country. Then there's equity and beneficiary safeguards. SHA has given priority to the most vulnerable households to ensure that the once registered indigent beneficiaries are entitled to maternal services free at the point of use, without facilities prohibiting from levying additional fees for covered services. And finally, I think the other question was, what has the ministry taken to ensure that access to Linda Mama services in the under-resourced, understaffed health facilities, and how it's addressing those barriers which are faced by our mothers. Honorable Speaker and members, to ensure access to maternal service in under-resourced and or hard-to-reach areas, the Ministry of Health, through the Social Health Authority, has implemented the following measures. Number one, digital registration deployment. SHA has deployed real-time digital registration platforms at all of our over 10,000 contracted health facilities countrywide, both public, private, and faith-based. And this allows pregnant women, including those in remote areas, to be enrolled instantly and granted immediate access to services without the administrative or financial delay. The second one is the community linkage through the community health promoters, who have been empowered to identify, to register, and to link pregnant women, particularly the adolescents and the vulnerable households, to the nearest accredited facility. This strengthens the last mile access, and it will ensure inclusion of mothers to hard-to-reach areas. Lastly, Honorable Speaker and members, we are targeting the under-resourced facilities. And how do we do this? The increased and the standardized fee for service tariff for maternal services is designed in order to create insensitize both for the private and the faith-based facilities in rural areas to remain contracted and sustain quality maternal care. And that's why I am very specific that in some of our most remote rural parts, the faith-based health facilities are available, and that's why we don't want to discriminate. Our mothers can go to either faith-based facility, they can go to private, if the public facilities are not available in that area. And then the last one is to provide evidence of the outcome achieved through the Linda Mama program since inception. Honorable Speaker and members, investing in maternal and child health is a proven strategy for improving the outcomes data from the Kenya Demographic and Health Survey, which demonstrates progress, and it attributes in part to increased access facilitated by the preceding program. And reduced maternal mortality. The maternal mortality rate declined from 362 deaths per 100,000 live births in 2014 to 355 deaths per 100,000 live births in 2019. Mr. Speaker, I am very ashamed to say that figure. There are many, many mothers. Kenya should not be at 355 per 100,000, 355 mothers die for every 100,000. Our peers, our regional neighbors are doing better. But the biggest problem I have for now is that even the data is old, is the data of 2014. Now, what we have done at the Ministry of Health, we have decided to do our own in-house data. And we must ask this House and the whole country that it should not be business anymore, that we can talk of maternal mortality rate of this figure. Mothers, when they walk to facilities, they are not patients. When they walk to facilities, they walk to facilities to go and give life. It is immoral, it's unconstitutional, and I think it is not acceptable for us to have this kind of high maternal and child death in our country. And I think at the highest level, from the presidency to the ministry to the houses of parliament to the leadership, all of us stakeholders together, we must discuss this openly. And what we are also trying to do now that we have digitized our healthcare system, in another 3 months, we will make it mandatory that every health facility in our country, be it private, public, faith-based, they must report maternal deaths and child deaths on a daily basis through a dashboard. Lower the... But I think going forward, as a ministry, we have a moral duty to do our own in-house every year, every 2 years, both every year, every 2 years, both for the infant mortality and for the maternal mortality rate. Of course, there is improved service utilization. The percentage of women attending at least 4 antenatal care visits in our country has increased from 52% in 2014 to 60% in 2019, indicating improved access. But when I walk around counties to do the SHA rollout, a number of leaders are not agreeing with this figure, and I agree with them because the data is old. The data is maybe 5 years, 6 years, 7 years. So we need to find out the correct data, and I am ready, willing, Mr. Speaker. I have set up a committee led by the Director of Medical Services, Dr. Amoth, to make sure that we get the right data. How many of our mothers die? We want to make it a mandatory that every health facility reports maternal and child deaths in our country. That is the questions for Honorable Senator Mutinda, Your Excellency. Thank you.
Senator Mutinda, do you have any supplementary questions?
Mr. Speaker. Bwana Waziri, thank you for your responses. And I want to agree with you that there is no single mother who becomes pregnant and wishes to die or even lose their child. I'm happy that you also note that. Now, I sit in the Committee of Health, and yes, Mr. Speaker, through you, we've really been visiting different counties, and recently we were actually in the Eastern region, and I want to agree that yes, when we ask the question of if SHA is working, the response is that SHA is working. I want to narrow my follow-up questions, Bwana Waziri, to part C. When I asked about the issue of the funds, your response specifies and says that Shif Act 2023, Section 27, has taken care of that. But when I look at Section 27, Bwana Waziri, it is much more on the contribution of Shif. I would want to know, Bwana Waziri, of the measures that have been put in place that there is a follow-up from SHA that ensures, you've explained that Linda Mama is not in place, but it has been substituted. What is SHA doing to ensure that there is a follow-up of these funds specifically for Linda Mama? At the same time, the issues of capacity building, Mr. Speaker. Waziri, you've talked about digitalization and transparency. I have noticed, yes, your team is on the ground doing the digital registration, especially to these young teenagers under 18 who have no national ID. Putting in place to ensure that even the young mothers who are not aware that they can actually get these services, they can know that these services are, that there is that capacity.
Yes, Senator Mutinda, avoid speeches. Go straight to the question, please.
Okay, Mr. Speaker. I know that of the young mothers we've met in hospitals, they have no even phone, they have no documentation. What has been put in place to ensure that even those ones with nothing are being assisted with the shortest time, because sometimes they always explain to us that they have just been kept in hospital, just waiting, to hope that things will be sorted within the shortest time possible. Lastly, Mr. Speaker, is mechanisms to monitor transparency and accountability of SHA funds from Linda Mama when they are remitted to the health facilities, and how SHA is looking forward to sort the challenge that is being experienced by most of the health facilities, whereby there's delayed reimbursement of the SHA fund to the health facilities. Hence, they are not able to continuously sustain offering the best services that they're supposed to offer.
Honorable
Thank you, Mr.
CS,
Speaker.
you may proceed to respond.
Honorable Speaker and the members, The current Linda Jamii budget is 900 million. And this budget is supposed to cover 400,000 teenage mothers across our 47 counties. And every year, the estimates, different counties, the estimate is about, we have in our country about 400,000 teenage mothers. And they are the ones who are to be covered by this budget. So far, from our record at SHA, through digitization, we have covered 22,000, paid for, and went home. The question is, how do we trace them? How do we get them? We have the numbers. We have counties with the highest numbers I can give. We have counties with the lowest numbers. County like Kakamega, Kilifi, the highest numbers. What are we doing to make sure we mobilize? We are talking to governors, we are talking to leaders, both political, church leaders, and we are mobilizing a very robust registration of teenage mothers and going with all our county governments. Everywhere we go, we give them the numbers, and we tell them, these are the numbers of teenage mothers who exist in this county. These are the numbers who have visited health facilities and who have accessed this free service. Please help us mobilize. We are using our community health promoters, and we are even urging the House and the leaders to make sure that all of us together, we are not promoting it, but we have no choice. They are our children, and we must protect them. So, including the leadership here, we really want to make sure that we increase our number from the 22,000 teenage mothers who have already accessed and cover all the 400. To date, Honorable Speaker and members, we have 476,553 deliveries, normal deliveries. And we have another 602 who went through cesarean delivery. Our community health promoters are well-trained, particularly in terms of registration of teenage mothers. And so far, the claim that SHA has paid, particularly on maternity, is about 9.7 billion to all health facilities at all levels in all the three categories of private, public, and faith-based. So if you look at what this House has passed, the Facility Improvement Fund Act, which ring-fenced funds at the facility for the improvement of those services. And these funds, to the good wisdom of this House, you have decided that the reimbursements must go direct to the facility, not to the county treasury fund, so that the facility can buy drugs, the facility can even hire healthcare workers, either on contract or locum. And all this is geared to make sure that the health facilities are managed better through the reimbursed funds in order for us to achieve key health indicators and priorities, Mr. Speaker. Thank you, sir.
Senator Mandago.
Thank you very much. My supplementary question to the CS is on the issues of reimbursement and clearance of mothers to leave the facility. Apparently, there is inordinate delay in hospitals, so that the mother can take another 3 days